Pre-eclampsia, prevention challenges and management. Now, I would like to emphasize that the definition and classification that I use is from the ISSHP. There are other definitions as well of pre-eclampsia classification and all that, but I think this is, to me, this is the best, most practical definition and classification. This dates back from 2014, the paper was published then, and it divides hypertensive disorders of pregnancy into 4 categories, and the last category, the newest, is white coat hypertension as well. And pre-eclampsia is defined very importantly not just with proteinuria. Okay, some, for example, NICE guidelines emphasizes on the importance of having proteinuria as an inclusion in the definition, but according to ISS, it's not an essential criteria because other maternal organ dysfunction is also important, and also uteroplacental dysfunction, the presence of which is essential, is one of the criteria that defines preeclampsia. So preeclampsia may be defined with or without proteinuria. Okay, right. Screening for preeclampsia. It is advocated to have combined first trimester screening, okay, which includes historical risk factors, mean arterial pressure, sonographic characteristics, like for example uterine artery pulsatility index and notching, and serum biomarkers, certain serum biomarkers, for example PEP-A or placental growth factor. And according to the NICE guidelines in 2011, you know this very well, I'm sure by now, high risk factors, moderate risk factors. Okay, if you have at least one high risk factor or 2 or more moderate risk factors, okay, then it is indicated to start aspirin. In the NICE guidelines, it says 75 milligram from 12 weeks gestation. However, more and more we are hearing evidence that a higher dose of aspirin is more justifiable and more appropriate. Okay, the high risk factors that you need to know is things like hypertensive disease during a previous pregnancy, chronic kidney disease, autoimmune disease, type 1 or type 2 diabetes, and chronic hypertension. And the moderate risk factors are first pregnancy, age 40 or more, pregnancy interval more than 10 years, BMI 35 or more at the first visit, I think of which we have so many patients, family history of preeclampsia as well as multiple pregnancy. Okay, and the reason why we want to screen for preeclampsia is because we do not want to burden the health system. Alright, it would be better if you could have more visits in, well, not to say more visits actually, a screening visit in the early part of the pregnancy, so that later on in the pregnancy you can discriminate between 2 cohorts of patients, one who are high risk and one who is low risk. Okay, the high risk of course will need to be monitored much more closely, and you can spend more of your time and your attention there. But the low risk patients you can send back to the community and do not need to be seen quite so often. And it has been shown that combination of maternal history, sonographic characteristics like uterine artery pulsatility index, mean arterial pressure, PEP-A, and placental growth factor as serum biomarkers, when you put all that in an algorithm, you can predict preeclampsia with a high detection rate of approximately 90% at the expense of 10% false positive. Okay, which is a very good detection rate. The Hong Kong group is at the moment on the verge of, in the process of doing such a study. It's called the Forecast trial under Professor Poon. And this is the study that they've done in Europe. And some of the placental biomarkers that can be used for screening for preeclampsia. Of course, the more biomarkers you use, the more expensive the whole exercise becomes. And according to the Esprit trial, which was published just last year in the ultrasound journal, in combined first trimester screening for preterm preeclampsia, okay, the detection rate was almost 80%, okay, for preterm preeclampsia. For term preeclampsia, it is lower, okay, the detection rate is only 43%, but our attention actually is emphasized more on preterm preeclampsia, which comes with more possibility of adverse outcomes in the, particularly in the fetus and in the mother as well, because there is a higher risk of the mother having to undergo cesarean section to deliver the baby, okay, when the preeclampsia is detected preterm. So there is a definite justification for prevention of preeclampsia because we have prophylaxis that we can use in order to prevent preeclampsia if we were to be able to detect those who are at high risk. Both low-dose aspirin as well as calcium, okay, particularly in the setting of low calcium intake in the population, are recommended for the prevention of preeclampsia. Aspirin, according to ISSHP, should be given between 75 and 150 milligrams per day. As I said, more and more the evidence points towards the higher of the dose, okay, either 100 or 150 milligrams per day. And the aspirin should be started preferably before 16 weeks, okay, and better to be taken at night and continued until delivery. There is no worry about aspirin causing premature closure of the ductus arteriosus beyond 36 weeks at the moment. Okay, the numbers needed to treat has varied from study to study. Okay, when this paper by ISSHP was published in 2014, the numbers needed to treat was 70, but that has come down a lot. Okay, particularly for the more severe forms of preeclampsia, the numbers needed to treat in order to prevent preeclampsia is lower. All right. And the dose of calcium that needs to be given in order to prevent preeclampsia is actually not quite decided yet, the dose as well as the timing for calcium. Alright, but generally it is said to be about 1 gram. Some groups even use 500 milligrams only, okay, of calcium carbonate. Okay, now if you look at aspirin, the mechanism of action, how aspirin prevents preeclampsia. We know very well that there is faulty immunological and vascular adaptation to pregnancy and preeclampsia between 8 and 18 weeks. Okay, now which is why the use of aspirin for prevention of preeclampsia is advocated to start before 16 weeks. All right. Of course, you can even start after that if you happen to see the patient late. Okay, but the possibility of a successful prevention, the efficacy is reduced after 16 weeks, yeah, drastically. And now the resulting endothelial dysfunction because of all those immunological and vascular adaptation problems leads to imbalance between prostacyclin and thromboxane A2. Okay, prostacyclin is produced by the endothelium, it's the good prostaglandin, and thromboxane A2 is from the platelets and is the bad prostaglandin. Okay, so a balance between these two is important for circulatory maintenance. Now, aspirin inhibits both actually, okay, because aspirin inhibits cyclooxygenase in general, and cyclooxygenase is responsible for synthesis of both these prostaglandins and prostacyclin as well as thromboxane A2. However, it inhibits cyclooxygenase irreversibly in the platelets. That means it inhibits the synthesis of thromboxane A2 in an irreversible manner. But in the endothelium, it inhibits prostacyclin synthesis in a reversible manner. Therefore, prostacyclin production can be re-established, whilst that of thromboxane A2 is totally inhibited permanently. Okay, as long as you give aspirin. So that's why at the end of the day, prostacyclin wins over thromboxane A2 when you give aspirin. So that's how aspirin prevents preeclampsia. Now, dosage, I've mentioned many times, okay, 150 milligrams is what is advocated at the moment. Cyclooxygenase inhibition by aspirin is dose dependent, therefore the dose that you give is important. Okay, if you give too low a dose, like for example 75 milligram or lower than that, then you may not be able to achieve any prevention. Okay, the balance of course is between what dose is effective and prolongation of bleeding time, which can happen to some extent. Okay, and the maximum potential benefit in terms of perinatal outcome is seen when aspirin is commenced before 16 weeks gestation, as I mentioned. Best taken at bedtime. Why at bedtime we do not know, but it has been shown in studies, okay, that it is best to take the aspirin at night. Reduction in the risk of preeclampsia varies from study to study, as low as 17% reduction to 62% reduction. Okay, and among high-risk women, the numbers needed to treat is as low as 19. I mentioned just now 70 in the ISS HP paper, yeah? Okay, but in high-risk women, the numbers you need to treat, meaning that how many women do you need to treat in order to prevent one case of preeclampsia, and that is as low as 19. If you treat 19 women, for example, not all of them will be prevented from suffering from preeclampsia, but at least one of them, okay, will be prevented, okay, from suffering from preeclampsia, which is a very small number. And aspirin being very cheap, it is definitely worth going for it. And on top of that, there are added benefits as well. For example, there is associated reduction in the risk of preterm labor up to 8%, and fetal and neonatal death of 14%, as well as prevention of fetal growth restriction of 10%. Okay, and there are low rates of adverse outcomes. So far, there is no association with placental abruption nor fetal intercerebral bleeding, although aspirin does cross the placental barrier. Okay, and this is a study published in 2017 also, last year, by the same group that produced the aspirin trial, aspirin versus placebo in pregnancies at high risk for preterm preeclampsia. And what they found is that the risk of preterm preeclampsia is reduced by 62%. The odds ratio is only 0.38, okay, which is a lot. Before this, meta-analysis only shows less than 20% protection, but this is 62% prevention of preeclampsia, particularly preterm preeclampsia, meaning that preeclampsia with an onset before 37 weeks. Okay, this is not just early preeclampsia before 34 weeks, but all preeclampsia before 37 weeks. Now, ever since the CLASP trial many years ago in the 1990s, the use of aspirin has been shown to be of good safety profile, okay, in pregnancy. And we know that aspirin is used in higher doses in heart disease and in thrombophilia in pregnancy, okay? And even with that, there is no teratogenic effects that are seen in the first trimester. The association with persistent pulmonary hypertension because of premature closure of the ductus arteriosus in the third trimester is just theoretical. It is an unfounded worry, okay? And there is no adverse childhood neurological effect except just in one study, the England trial, which showed an increased risk of cerebral palsy in infants born before 28 weeks. But then we know that infants born at 28 weeks are at high risk of cerebral palsy anyway, right? Aspirin crosses the placenta, but it still doesn't show any adverse effects on the baby, like intracerebral hemorrhage in the fetus or anything like that, nothing, okay? And if the dose is more than 40 milligrams per day, which is what we advocate, all right, if the patient were to go into labor, then it would be best to, if possible, to stop it pre-delivery. And of course, if the patient is going for elective C-section, then you would have to discuss with your anesthetic colleagues as to when is the comfortable time for them to stop aspirin before the C-section. Now, calcium. The daily requirement of calcium in a normal pregnancy is 1,000 milligrams per day, and all over the world, only 6% of women can fulfill this requirement from dietary intake. Very small number. Alright? Because the fetus accumulates a lot of calcium, okay, throughout pregnancy, particularly in the 3rd trimester. And calcium deficiency has been linked not only to preeclampsia, but also to other complications of pregnancy, such as fetal growth restriction and preterm labor. So you can see how important calcium is. For that matter, actually, it is not just calcium. I believe that there's a lot of micronutrients out there which are important, particularly for pregnancy, and even in the non-pregnant. You know, calcium is just one of them. Okay, there has been studies on multiple micronutrient supplementation in pregnancy, involving calcium, iron, and many other things. You know, many other elements, and it has been shown that there is improvement in multiple pregnancy outcomes. Okay, it's the summit trial. I think it was done in Indonesia and Bangladesh. How calcium does its work, we do not know. Okay, but at the moment, there are two important elements which are not solved yet. One is the dosage of calcium, how much should we give, okay, and the other one is when should we start calcium. At the moment, it is advocated to start from 20 weeks of gestation until the end of pregnancy, okay, but people are looking at earlier than that. In Malaysia, if I can tell you from our study, we found that almost 40% of women take less than 600 milligrams of calcium per day, even when you include milk and the usual calcium supplements that they take at that period of during that time. Okay, during the time of that study, before we implemented all this, the new concept of giving calcium supplement. Okay. And evidence have shown that calcium supplementation reduces the risk of preeclampsia by about half. Okay, especially in women with low calcium levels or low calcium intake and who are at high risk of preeclampsia. Calcium also reduces the risk of preterm labor, okay, and maternal death or morbidity. And although at the same time, calcium may increase the risk of HELP to a certain degree. Okay, so if the woman happen to still develop preeclampsia, then the risk of developing HELP may be higher. All right. So dosage and optimal time of commencement are the two aspects that we have not solved yet. Okay. Side effects: difficulty in swallowing, increased urinary stones, increased UTI, and reduced absorption of other minerals, for example iron. Okay, so they should not be taken at the same time because they are both divalent cations. Okay, so they compete for the same absorption channels. And since the mechanism of action is believed to be different between aspirin and calcium, definitely calcium does not have anything to do with prostaglandin synthesis. Both can be prescribed simultaneously in a woman at high risk of preeclampsia, and we hope that there is like sort of either synergistic effect between the two, or at least independently they reduce the risk of preeclampsia. Now, we know that most developing countries, the women have low calcium intake. I've just mentioned to you the example of Malaysia. The mean intake of calcium in Malaysia actually is about 700 to 800 milligrams per day only, not reaching the 1,000 milligrams per day, which is supposed to be the target. Okay, and in this systematic review of low-dose calcium supplementation, okay, for preventing preeclampsia, the Canadian group has shown that preeclampsia was reduced consistently with low-dose calcium with or without co-supplements. Okay, and the relative risk was 0.38. So again, 62% reduction in preeclampsia with calcium supplementation. In this study, the amount of calcium taken is less than 1 gram per day, the supplement that was given. Okay, so it's like 1 or 2 tabs of calcium carbonate per day. This is the CAP study, which tries to address the issue of particularly the starting point of giving calcium supplementation. Okay, it's the Canadian group in collaboration with WHO. Okay, what they do is they give one group 500 milligrams elemental calcium daily from before pregnancy until 20 weeks gestation. The other group was just given placebo. Then from 20 weeks onwards, they were given 1000 milligrams of calcium until delivery, both groups. So that study is ongoing. And this is another paper stating the benefit of calcium in pregnancy. Okay, calcium supplementation reduced risk of preeclampsia by 52%. This was published in 2012. Okay. Now, there may be some unexpected long-term effects of calcium supplementation in pregnancy on maternal bone outcomes. Okay, so these are the things that needs to be people need to be a bit cautious about as well. Okay, what has been found in rural Gambia, okay, in a population of women with low calcium diet, a calcium supplement of 1500 milligrams per day during pregnancy resulted in lower maternal bone mineral content in the subsequent lactation that persisted long term. Okay, so that is one precaution about taking calcium, too high a dose of calcium in pregnancy. Okay, so the dose has got to be just nice in order to prevent preeclampsia. Perhaps not too high as well. Okay, management of preeclampsia. How do we manage these women if they develop preeclampsia? Women with an initial diagnosis of preeclampsia should be admitted to hospital in all cases. If you diagnose preeclampsia, this is not just gestational hypertension, yeah? Okay, they either have accompanying proteinuria or some element of organ impairment or fetal growth restriction. Okay, those are the 3 criteria for you to say that they have preeclampsia. And blood tests should be performed at least twice weekly. You know what they are: full blood count, liver enzymes, and renal function test. Okay, including uric acid as well. And there is controversy about giving antihypertensive therapy in terms of what is the target blood pressure, when do you start, and what is the target blood pressure. Okay, now what is clear is that blood pressures above 160 to 170 systolic or 110 or more diastolic require urgent treatment, no question about that. Okay, and in the acute setting, short-acting oral nifedipine or intravenous labetalol or hydralazine is commonly used, okay, for control of such high blood pressures. There is no current agreement as to what level of blood pressure should be maintained when antihypertensives are instituted. Okay, according to the Canadian guidelines, the target should be systolic of 130 to 155, diastolic of 90 to 105. Okay, the NICE guideline says the systolic blood pressure should be kept below 150 and between 80 to 100 diastolic. Okay, so both of those are acceptable. Okay, what is important is not to lower the blood pressure too low, because that will be associated with poor placental perfusion. Alright, the systolic blood pressure definitely has got to be maintained above 110. diastolic above 80. Okay, not lower than that. So there is this CHIPS trial, okay, looking at less tight versus tight control of hypertension in pregnancy. Okay, now about 3/4 of the women enrolled in this study are actually cases of chronic hypertension. Okay, it was found that there was no difference between the two groups, less tight and tight blood pressure control, in terms of risk of pregnancy loss, high level neonatal care, as well as, in other words, NICU admission, as well as overall maternal complications. Okay, now two significant findings from the study is that with less tight blood pressure control, there are more women who develop preeclampsia with severe features, 38.3%, significantly higher than the group with tight control. However, on the other hand, as expected, in the group with tight control, there are more babies with birth weight less than 10 centile, 19.7%, compared to the group with less tight blood pressure control. But, you know, the difference between the tight control and less tight control in terms of birth weight less than 10 centile is believed to be unlikely to be of clinical importance, because it's just a small percentage difference, yeah? About 20% versus 14%, 6% difference. And there wasn't any other adverse effects on the baby other than just the birth weight. Okay? What is more important is that if you exercise less tight blood pressure control, the mother may suffer more preeclampsia with severe features, almost 40%. Okay, and that's very important. About 10% difference with the tight control. So there is always this balance between fetal harm and maternal harm. Which one do you want to save? Okay, and as we all know, the golden rule in obstetrics is to prioritize the mother first. Okay. Now, it is important to remember that there is difference in blood pressure control in pregnancy between chronic hypertension and preeclampsia. As I mentioned in the CHIPS trial, about 75% of the women are those with chronic hypertension. Okay, the pathophysiology of chronic hypertension has no relationship with uteroplacental circulation. Okay, whereas in preeclampsia, the pathophysiology is clearly related to uteroplacental circulation. In chronic hypertension, hypertension is not secondary to uteroplacental ischemia, okay, compared to preeclampsia where it is secondary to uteroplacental ischemia. And in chronic hypertension, the physiological pattern of blood pressure variation in pregnancy remains, whereas in preeclampsia, that pattern is gone. Okay, you don't have that pattern. Okay, what I'm trying to say is, if you look at this serial blood pressure before pregnancy, during pregnancy, until delivery, okay, somebody with purely chronic hypertension will follow this pattern. In mid-pregnancy, the blood pressure will fall drastically, even up to normal levels. Now, it is very important to recognize that for patients with just purely chronic hypertension, you do not have to be alarmed and stop the antihypertensive treatment in mid-pregnancy onwards just because the blood pressure drops in mid-pregnancy, because it drops in the same pattern as a normal pregnant patient. It's just following the physiological change in blood pressure variation. Okay, so no need to be alarmed and no need to stop the antihypertensive treatment when you see that happening in a patient with chronic hypertension. Just continue the antihypertensive. Okay, that is where a lot of people have a mistake. Okay, now in chronic hypertension, blood pressure drops in second trimester as in normal pregnancy. Okay, therefore treatment does not need to be adjusted. Okay, because it's physiological. Alright, only when there are anomalies in the physiological variation, then you have to increase surveillance and be suspicious that there may be superimposed preeclampsia. For example, if in the mid trimester suddenly the blood pressure goes up rather than come down, okay, then you'll be alarmed. Okay, but if it comes down, no need to intervene with the treatment. Okay, now in preeclampsia, on the other hand, the blood pressure may show a rise instead of a fall in the second trimester. Okay, and in the third trimester, of course, it rises up higher. and there is a loss in the normal physiological diurnal BP variation, which is why your patient in deep sleep at 4 a.m. in the morning may have a sudden hypertensive crisis, okay? And other associated preeclampsia related problems may coexist. Okay, I'm finishing not very long from now. Thanks for the warning bells. And this is what the Canadian group says, okay? We would caution against regarding progression to severe hypertension as something that can be identified and treated, because that was what critics of their study of the CHIPS trial said, okay? They said failure to identify and treat hypertension has been recognized in reviews of maternal deaths as the single most important failing in the care of women with pregnancy hypertension. So you should be more alarmed if the blood pressure goes up, and not so worried about blood pressure coming down in a patient with chronic hypertension in mid-pregnancy. Okay, just carry on with the antihypertensive treatment. Anticonvulsant, I don't have to say so much. You know, still magnesium sulfate is the treatment of choice. Okay, and it is better to have a low threshold for starting rather than a high threshold. Okay. And it is better not to worry so much about who has mild and who has severe preeclampsia. They are all basically almost the same, because the mild ones may suddenly even accelerate to become severe preeclampsia. So don't be too confident about somebody who is supposed to have a label of mild preeclampsia. Okay. And there's one situation where a patient with preeclampsia really needs thromboprophylaxis. Okay. In those with nephrotic syndrome levels of proteinuria. If they have proteinuria of more than 3 grams per day, they may have a contraction of the intravascular volume, severe hemoconcentration, and they may end up with thromboembolism. So that is where you really have to give them good thromboprophylaxis. Okay. And delivery, where delivery is concerned, more than 37 weeks and more, deliver if you recognize preeclampsia. Okay. For chronic hypertension, gestational hypertension, white coat hypertension, you can delay that until 40 weeks, the delivery. Okay. And just to point out some variations in preeclampsia guidelines, mainly in the area of requirement for proteinuria as a feature for diagnosis, which is what NICE recommends, but not by ISSHP. Okay, and I think ISSHP is more reasonable. The level at which routine antihypertensive treatment is mandatory and the target blood pressure also varies from one guideline to another, and when magnesium sulfate should be administered. Magnesium sulfate is actually very safe. The risk of toxicity that causes cardiopulmonary collapse is very low. It's about 0.02%. So you don't have to be worried about it. Okay. So in conclusion, prediction of preeclampsia is important by screening at 11 to 13 or 14 weeks gestation, and prevention of preeclampsia has been established with aspirin and calcium. Of course, there are a lot of challenges in the screening and prevention exercise, particularly in the aspect of impact on healthcare cost, especially with screening using biomarkers. And accessibility to screening is also another thing. It's at the moment more accessible to the wealthy, and not accessible at all to those in rural areas. And the other thing is to change people's practice. Yeah, embracing change is not that easy. And in terms of management of preeclampsia, okay, the cutoff value of blood pressure to start antihypertensive, okay, is another thing which, as I said, not so clear cut, but you have the various guidelines to for a start. And the tightness of blood pressure control, it would be better to be a little bit tight for the sake of the mother, and use of magnesium sulfate should be more liberal, and aim to deliver between 37 and 40 weeks depending on the type of hypertensive disorder, the severity and presence of complications. Okay, that's all. Thank you very much.